shy and want to ask me questions some other time.
Questions? Yes.
David Dirac from Becklin Dickinson. Thank you very much. The Katie trial is very instructive, but could I argue that the differences that you found there would be much less likely to occur when you're dealing with devices? Isn't this typically a drugs and genetic predisposition kind of argument for those differences that you described rather than you would see with a device?
I think it depends on what device, I think. I mean, maybe as a class, maybe as a broad category in medical products, there are few devices where this heterogeneity comes up, but for some devices there is, I think.
Other questions? Yes.
Thank you. Amelia Issa from the University of Houston. I enjoyed your talk. With respect to your discussion of heterogeneous treatment effects and the issue of the possibility that a particular product or treatment being declared a loser, and then some patients perhaps responding to that given product, can you elaborate on the role that personalized medicine might play in CER, comparative effectiveness research?
Well, personalized medicine, I think there's two things that personalized medicine might do. It might tell you that you shouldn't be consuming a given product, which I think is less likely. I don't think we have $1 billion sales of some of these products, even though they're not working. So somehow people figure that out. The more important, I think, is can we tell who's not going to respond or who's going to have a severe side effect from a product? So we've done a study on COX-2, for example. And it's an enormous value of a diagnostic that would tell you, if your COX-2 wouldn't work, because you're opening up a whole market. So there's two effects of personalized medicine. One is the first effect, which most people talk about, which is the shrinking of market. The other one is the expansion of market, because you can now rule out people are not going to respond. So the CR, again, I think is going to be, if you have CR policy being product specific, that's very dangerous for personalized medicine, I think. Because personalized medicine is aimed at saying which products work for which people. So you definitely want to get away from the product specific, and you will, depending on what CR reimbursement policy, whether explicit or implicit, that takes place in response to this evidence, the incentives for personalized medicine will be very, very different. Because some personalized medicines, for example, could say we're going to shut out we're going to shut out the non-responders from the population. Therefore, our treatment effect is going to, on average, look much better. And now we're going to come in under this product looking like a winner because we shut out the non-responders from eliminating them from the pool. Okay, if you have product-specific kind of policies. But I mean, personalized medicine is all about figuring out what works for whom, and CR as is currently envisioned is too broad-based for that, I think, to get the right incentives to develop personalized medicine.